Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us. Good morning, Thursday, September 10th. We're going to give you a little COVID-19 update today. It's been a couple weeks since we did one of those, so there's obviously a lot of news every day, so we're just going to go over a few things that we think are interesting to talk about. So where are we with the pandemic? Well, globally, data from the Financial Times shows that the global coronavirus death rate has continued to decrease slightly. The 7-day rolling average of daily deaths is down to a little over 5,000 right now, which is about 300 fewer than a week ago. The rolling average daily deaths in the U.S. is also down a little bit. It's about 809 deaths. So down is good, but I don't think we can claim victory yet, Mike. I want to point out that we honestly, well, personally, I shouldn't speak for everyone. I really expected a big decline in the summer. So I'm glad these numbers are going down, but I am still pretty worried about the fall and the winter. So it's good the numbers are going down. I wish they were even lower, and I think we definitely have some work to do if we don't want to have a really bad situation in the fall and the winter. Some places are doing better than others. On Sunday, Governor Cuomo announced that the percentage of coronavirus tests that have returned positive has stayed below 1% for the last 30 days. That's pretty incredible. Especially, so we're doing a lot of testing even for asymptomatic folks, and our tests are coming back over 1% for asymptomatic. So I almost have a hard time believing that statistic, just seeing the thousands that we're doing. I mean, we have done over 30,000 tests on college campuses, and we have well over 1% positivity rate with asymptomatic healthy individuals. But it is good that they have a rate close to that low, whether it is actually below 1% or not. That low positivity rate tells us that the widespread testing that's being performed is probably catching most of the actual cases. That's the reason we talk about this positivity rate instead of just the numbers, is because once you start having a rate over 10% positive, or even up what we've seen in some places like 20%, what that tells you is there's an incredible number that you're not testing that have it. So that's why this percentage rate is so low. Mike, any recent research or articles you want to talk about?
Definitely. I've got 3 here that I want to talk about. The first one's actually not really an article. It's just something that I'm sure you probably heard about that was on the news just yesterday. So AstraZeneca just announced that they are basically stopping or putting a hold on their phase 3 vaccine trial. And they're doing this because one of the participants in the trial developed transverse myelitis. So for those of you that don't know what that is, it's an inflammatory condition of the spinal cord that's often related to viral infections. So AstraZeneca was one of the front runners in terms of vaccine production coming out of the University of Oxford. This is a big study. Everybody had their fingers crossed that things were going to go well and that we'll get a vaccine out of it. The thing that I want to say about this, Matt, is that this does not mean that the vaccine's not going to work, and it does not mean that the vaccine's going to cause transverse myelitis. This is something that the media has picked up, and they've made a giant deal about. And I think because everybody's nervous and they want a vaccine, but this happens all the time. I mean, anytime there's an adverse event like this in a study, they're going to put a hold on the study. They're going to take a look at it and try to determine whether that came from the actual vaccine itself or from the medication that's being given. So everybody chill out, give science a chance to work. And the other thing that I want to mention about this is I think it's proof that we can't rush a vaccine. I mean, we're going to have to give these vaccines the opportunity to prove themselves and to prove to us that they're not going to be harmful to us when given. And if we try to push that, even for political reasons or because everybody's scared or for whatever reason, then the science is not going to have the opportunity to do its business, and we're going to end up with bad outcomes. So everybody relax. Give it the opportunity. We'll know more in the future in terms of whether this was related to the vaccine or whether this was just random transverse myelitis that happens to people, without getting a vaccine. There's no way to know that right now.
I don't know. I mean, I get probably 2 videos a day sent to me that are pretty convincing about how the vaccine is basically designed to control our minds or exterminate the human race. So I think this is just proof that no, I'm joking, and I shouldn't.
Yeah, well, it's probably all 5G related.
And I shouldn't even joke about it because it's kind of crazy the amount of conspiracy theories out there. And as you started talking about this case, I was like squirming a little bit just listening because I was just thinking everyone is going to grab onto this and when the vaccine is ready and say, well, did you hear about the guy with the horrible outcome when they were testing it? And now look, we have a vaccine anyway, But you're right. I mean, when Dr. Fauci weighed in and said this is a necessary and not uncommon safety valve in the vaccine development process, that's true. Like this is, if people are worried about rushing the vaccine, we should be pointing to this as, no, look, we're not. Like this is being reported. This isn't being hidden. It's not being swept under the rug. We're actually talking about this, trying to be transparent, and that's important. But if the scientists and these companies are transparent with this, then we have to also be reasonable and understand what it means. It doesn't mean that the vaccine that eventually will come out is unsafe. It just means this exact formulation may have been, and we don't even know that for sure. So I think...
And this is exactly what is supposed to happen. I mean, I've been involved in these large randomized controlled trials, and when there's an adverse outcome, if it's bad enough, you hold the trial, you get down to brass tacks, you talk about it as researchers and research it and try to figure out exactly what happened. And that's exactly what's supposed to happen. So nothing bad is currently occurring. I mean, obviously somebody had a bad outcome, but that doesn't necessarily mean that is a negative thing for the study. The fact that they're actually doing it right really actually gives me some confidence in the process.
You do it right. You report these adverse events, and then at all costs, you make sure you have a vaccine out before the election. No, not the last part.
Okay. Skip that last part. All right, let's move on before we dig our hole. So the next study I want to talk about is some good news. Love the studies with actually, man, we got lots of good news today. So 2 more studies of good news. This first one is out of Iceland, and the reason I think this is interesting is because it's really mostly just epidemiologic data, but it gives us some confidence that the antibodies are going to hang around for at least a reasonable amount of time. So this was a large study looking at antibodies, serum samples of over 30,000 Icelandic peoples. And they not just did they look at those 30,000 people, but they followed a subgroup of them out for 4 months to look and see, when did the antibodies peak? How much did they trail off? And the good news, Matt, is that they didn't see any trail off at 4 months. So 91% of people who had a positive PCR test ended up seroconverting, which is consistent with previous data that we've seen. So about 9 out of 10 people are going to make antibodies. And of those people in this group, virtually none of them lost any significant amount of antibodies after 4 months. So that does give me some hope that we're going to see, as we continue to get data on the subject, a progression where we continue to have antibodies for a reasonable amount of time, which is important for vaccines, which is important for getting back to work, which is important for, obviously everything regarding this virus. So I think this is
it's good data because we've been guessing for a while. Like we want to know how long are people immune from this, and we know we have some data from some of the coronaviruses where it's as early as 5 months it starts to wane. And then SARS-CoV-1, it's probably at least a couple of years. So where is SARS-CoV-2? And we've started to get these reports of potential reinfections. And we know it's going to be a bell curve. Like some people, there will be a few early folks, like the couple cases we've seen. There'll be a few that have immunity for a long time. But getting a big data set like this is really nice to show that for the vast majority of people at 4 months, we're still good. And then we'll be getting more data as more time passes. But I agree, this is really positive news, especially with the recent potential reinfections that we've talked about.
Absolutely. Last study I want to talk about, Matt, another happy study. This one's a meta-analysis called Association Between Administration of Systemic Corticosteroids and Mortality Among Critically Ill Patients with COVID-19. So this was published in JAMA, I believe, one of the JAMA Network articles on September 2nd. And this is a study that is a meta-analysis. So what they did is they went back and looked at 7 randomized controlled trials with relatively small numbers, and they grouped those numbers into basically a larger study. So of all, about 1,700 critically ill patients. So these are patients who are in the ICU, not all of them ventilated, but definitely hospitalized patients that are not doing well with COVID-19. And this was conducted in 12 different countries, so we've got a nice different population. And they basically looked at pooled averages of patients that got corticosteroids, systemic corticosteroids, things like prednisone, methylprednisone, and patients who did not. So patients were randomized to either getting the steroids or not getting the steroids. And then they looked at basically the odds ratio of mortality. So this is a mortality-based study. And basically the summarized mortality rate in this group was in the 0.65 range. So depending on which specific corticosteroid they got, it was like 0.64 or 0.65 or 0.66, depending on the corticosteroid, which is a pretty impressive improvement with corticosteroids. So this is making me feel pretty good about steroids. I mean, granted, it's still a meta-analysis, so it has some disadvantages in that you're basically just pooling smaller studies, and smaller studies aren't as strong. But this is just, I think, more data for us to really start to feel comfortable administering corticosteroids in the critically ill patients. The important thing to remember here, and I think the take-home point, is that this is not in people who are staying home with COVID. This is not in patients who are just barely ill, just barely requiring oxygen in the hospital. This is critically ill patients. And it's important to note that of those critically ill patients, the people who got the steroids, 64 out of 354 patients had an adverse event that they think is secondary to the steroids. So there are negative effects of taking steroids, and if we just start administering them to anyone with COVID, you're going to see those negative effects have a much greater effect than the benefit towards mortality. So it's important to remember that it's a very specific group, the really sick patients, not the everyday schmo who has COVID and at home watching YouTube.
Yeah, I guess I would disagree with you on one thing there. You made a statement. I wouldn't necessarily disagree. I just don't think we have any evidence for it. You said, I agree that just outpatient folks, asymptomatic or just very little symptoms, we don't have any evidence. But steroids we've used for a long time. We give them to people outpatient all the time for asthma, COPD exacerbation, poison ivy, so many things. So I don't know if the negative effects would be higher than the positive effects, but I think your point is that we don't know. We don't have any evidence if the benefits outweigh the risk, and so we definitely should not be just giving them to everybody that has a positive test.
Certainly true. It's also important to remember, though, that these steroids have a very similar effect as ibuprofen or NSAIDs, and we are basically recommending to people not take NSAIDs because there's this theoretical negative effect associated with it. So, until I see data, I don't think I can recommend to anyone to take steroids on an outpatient basis. But I'd love to see some data. I really do hope that we get there, because keeping people out of the ICU could be the first step to not having sicker patients. So if steroids were beneficial in that case, that would be awesome.
Yeah, hopefully someone's doing that study, because it would be a great data to know. We just don't know right now. The last thing I'd like to talk about, Mike, was really interesting. This was published yesterday in the New England Journal of Medicine. It's a perspective. It's not a study, but it's an interesting idea. And it's titled Facial Masking for COVID-19, Potential for Variolation as We Await a Vaccine. So the point of their paper was basically, could masks be a poor man's vaccine? So if you think about this, vaccines, a lot of vaccines, there are different types of vaccines, but a lot of them are a weakened virus or dead virus. And we also know that how sick you get is partly due to the load of virus that you're exposed to. And so what they're hypothesizing is that wearing masks and getting exposed to a little bit of virus, maybe you get an immune response without actually getting sick, which is an interesting idea. And the first thing to say about it is, it's absolutely impossible to test this. There's never going to be a trial where we expose people wearing masks or not wearing masks and see what happens. But there is some really cool data that points to this maybe being true. So for example, first off, we know that masks work. There's pretty good evidence, epidemiologic at least, from like the 2003 SARS pandemic showing that population-wide masking actually does work and has an effect. We also know even with this pandemic, there's some data out of Boston showing that healthcare workers, after universal masking was implemented, had lower rates of infection. So we do know that is the case, that masks work. Now, could you get exposed to a small amount of virus and have an immune reaction and then be immune? That's the next question. So we know people should wear masks. And we do know that there's a concept called an LD50 with viruses. So we've known that for a while in animal models specifically. Like, what is the lethal dose that if you give 50% of the host will die? So we know that the load matters. How much does it matter in this disease? Well, we know for sure that in hamsters, it makes a difference. So there was a study in hamsters where they definitely proved that the dosage matters. Actually, it was in Syrian hamsters. I'm not sure about American hamsters if we can apply it or not. But they had simulated surgical masking, and the hamsters were less likely to get infected. And the ones that did get infected, when they were wearing a mask, they weren't actually wearing a mask. They had like a mask screen thing up. They were either asymptomatic or had milder symptoms than the hamsters who weren't wearing masks. So in hamsters, at least, we proved this theory. And again, we can't do a study in humans, but there is some interesting data on potentially this being the case in humans. And what I mean by that is for example, there was an Argentinian cruise ship where everybody was this kind of a closed system everybody stayed on, and all the passengers were provided with surgical masks, and then the staff had N95s, and the rate of asymptomatic infection was 81%. And when you compare that to earlier cruise ships where they didn't have universal masking, the asymptomatic infection rate was only 20%. So a much higher percentage of the infected people were asymptomatic. And then an even stronger case for it, there was a couple recent outbreaks in food processing plants. We've talked about these before, where people were kind of working close together. And in these cases, all the workers had masks. And we were talking about this in the early days. That wasn't the case. But in these cases, everybody had masks. They were issued every day, and they were required to wear them. So they had 500 people who became infected in these two outbreaks, and 95% of them were asymptomatic. And only 5% in each of those outbreaks had mild to moderate symptoms. So really strong case for this potentially being true, that by wearing a mask, you may still get it, but there's a good chance you're going to be asymptomatic or have a really low burden of symptoms. So what does all this mean? Well, I don't really think it means anything that you should be doing differently. I talk about it because it's interesting, but in the end, what we know is that masks work, okay? First off, masks work. We should be wearing masks. What I don't want is for people to start getting cool ideas around this and be throwing COVID parties with masks, for example.
It's hard not to listen to you, Matt, and start thinking about the numbers. Like I just did a quick search, and I think you're actually talking about the ID50, which is the infectious dose.
Well,
not the
yeah,
LD50.
I was specifically talking about the
ID50.
LD50, but more applicable because that's what we have animal models on. But the ID50 is what we're more concerned with right now, for sure.
Right. So the ID50, for example, for influenza is like 800 viral particles. And for SARS-CoV-1, it's like 250 viral particles. But it's probably even lower than that for SARS-CoV-2, because we know the R value for SARS-CoV-2 has been higher than influenza and SARS-CoV-1. So it's probably less than 200 viral particles. So now I'm thinking to myself, like, all right, which mask do I want to wear if I want to get, like, say, 80 viral particles? This is definitely not what you should be thinking about. Like, I think it's really interesting, and I do think it's probably researchable. You said that you'd never have the study, and sure, you'd never have like a randomized control study, but if you could find, two fairly similar situations where one group of providers, healthcare providers, say for example, had inadequate PPE and another had adequate PPE, that would be a really interesting group to sort of compare. Like, say for example, you only had surgical masks in one group and you had N95s in another group, and then see what the seroconversion rate was between the groups, as well as as the infectivity rate, because then you could start to get an idea of like, is there actually this possibility that you could be getting exposed without getting actually sick? That would be
and we kind of
cool.
We kind of did have the comparisons when it comes to just the timing. So like I mentioned with the cruise ships, the early outbreaks, when of the people who tested positive, only 20% were asymptomatic, whereas in this one where masks were required, 81% of the people that were infected were asymptomatic. So we have it a little bit, but not really as robust as what you're describing, where we talk about percentage infected. The numbers I just gave were how many of the infected were asymptomatic. So I guess, again, just to bring it home, don't start having parties with a lot of COVID positive friends and you wear a mask and then you try to like open your mask just a little bit to let in a certain number of viral particles, because that doesn't make sense. You're not going to be doing that. The take home message of this is wear your mask. And this is good news. I don't know how good news is because I don't know how true it is, but it seems like a plausible thing. And while I say this is good news, I think now that masks are mandatory in most places, I think we're going to start seeing a lot more asymptomatic positives, a lot more people who get some immunity, who don't actually have to go through the horrible illness. So a lot of good news today, Mike.
Yeah, I bet we see less influenza this year too.
Oh, no doubt. That's one of the hopeful things. Like, I'm really worried about having both influenza and COVID over the winter. But yeah, the influenza, certainly I think it's going to be less than what we normally get. It's still going to be bad because we have it on top of the regular pandemic. But if we do a good job wearing masks, I think we've just got a lot better chance of getting out of this unscathed.
100%.
Well, thanks for listening. We have a couple great podcasts coming up, kind of very exercised focused. So if you're into fitness, you want to get ripped or swole or just live a long time, tune in for those coming up in the next couple weeks. I think the worst promo ever.
Thanks, Matt. Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.